Hello and welcome. We'll get started in just one moment. We are getting started in just one moment. We're waiting for everyone to join us in the room. Well, welcome. We are so glad that you are here with us this morning. While we're waiting for everyone else to join, we're going to go ahead and launch our first poll question, and it'll be on the screen momentarily. As we're all gathering, we would love to know what state you represent today. We will have several polls throughout this program, and we really appreciate your participation. So as we're wrapping up the poll, let's go ahead and get started. My name is Casey Faber, and I am the Senior Manager of Cancer Control Strategic Partnerships for the American Cancer Society in Ohio and West Virginia. We can move probably to the So it's my pleasure to welcome everyone to the event today. We ask that if you've called in from a phone number today, you please enter your name and your organization in the Q&A box so that we have a record of your attendance. All lines will be muted during this program, and we ask that all questions be entered into the Q&A tab on the screen. We will be taking questions at the end as time permits, but if we don't have time to answer a question during the Q&A, we will work with our presenters to have your question answered post-event. I now have the pleasure of introducing Harsha Kapoor. Harsha has been with KeyBank since 2008 and has held various leadership and executive positions with increasing responsibilities. In November 2020, as Key prepared for the launch of the new National Digital Bank, Harsha was named as a Chief Banking and Risk Officer for Laurel Road, a brand of KeyBank, while maintaining her current role of Head of Business Risk and Controls and Shared Services. Harsha is a member of the American Cancer Society North Central Region Board of Directors. And I will now turn the program over to Harsha.
Thank you, Casey, and welcome to everyone. I just want to take a few minutes to say thank you for attending this webinar and also being a part of our cancer prevention work. Preventing cancer is very near and dear to my heart. I lost my mom to cancer about 4 years ago and have been on a journey to help wherever I can with cancer prevention, just understanding the toll it takes on the patient, but then also the caregivers and the family members and friends around them. So anything we can do to help advance this cause, I think, is very near and dear to me. So thank you all again for being here. And before I turn over the program to Casey, I wanted to recognize and thank our sponsors. So without the generous support of the Ohio State University, Dayton Children's, Cincinnati Children's, the Harry C. Moores Foundation, and Anthem Blue Cross Blue Shield Foundation, this program would not be possible. Also, thank you to the Ohio Partners for Cancer Control and Mountains of Hope Comprehensive Cancer Coalitions for their support and dedication to this program and the fight against cancer in Ohio and West Virginia. So thank you again, everyone, for being here, our sponsors. And Casey, I'll hand it off back to you.
Thank you so much, and thank you for being a part of this morning. On the next slide, we'll just, again, briefly, these are our sponsors for today, and we could not have done this without them. On the next slide, this is going to be our agenda for the day. So we're going to start our morning off with Dr. Electra Paskett talking about health equity HPV for cancer prevention. Then we're going to have a panel with some partners who are doing some amazing innovative work to reach diverse populations with HPV vaccination. We have Elaine Darling, Dr. Adam Keating, and Dr. Melinda Butch-Kovacic are going to be sharing during this presentation. Then we're going to do a short video about the American Cancer Society's Gold Together program and a brief message about the ACS HPV Learning Collaborative. Lastly, you will hear from Christina Turpin, who will share the tools and resources available to you from the American Cancer Society to address health disparities in HPV vaccination. On the next slide is some information about our continuing medical education credits. So the Ohio chapter, American Academy of Pediatrics, is accredited by the Ohio State Medical Association to provide continuing medical education for physicians. The Ohio AAP designates each live activity for a maximum of 2 AMA PRA Credit 1 credits. Physicians should claim only the credit commensurate with the extent of their participation in the activity. Successful completion of the CME activity will include participation in the activity with individual assessments of the participant and feedback to the participant. So you'll receive your certificate to claim your CMEs within 2 weeks following completion of the post-event survey. Our objectives for today's event can be seen on the current slide. Please note that the planning committee members and speakers have declared that there are no relevant financial arrangements or affiliations with the organization that may affect balance, independency, objectivity, or scientific rigor for the CE event. Also, please know that the slides will be available after the presentation and the event is being recorded. And now it's time for our second poll. Which of these sectors would you say you most accurately represents your role as it relates to HPV vaccination and cancer? Thank you so much for participating in the poll. On the next slide, we will introduce Dr. Electra Paskett. So she's going to be our first speaker of the day. Dr. Paskett is a professor and director of the Division of Cancer Prevention and Control and the Department of Internal Medicine at The Ohio State University College of Medicine, where she holds the Marion N. Raleigh Designated Chair in Cancer Research. She also serves as the Associate Director for Population Sciences and Community Outreach, co-leader of the Cancer Control Program and Director of the Diversity Enhancement Program at the OSU CCC James. Her research program is nationally recognized for studying cancer health disparities. We are especially excited to have Dr. Paskett fresh from the 2022 ASCO meeting where she was awarded the ACS ASCO Cancer Prevention Award for her tremendous impact on the field. Please welcome Dr. Paskett.
Good morning, everybody. Thank you so much for joining us this morning, and so glad to have a few minutes to share with you a little bit about HPV and delivering HPV vaccine equitably so that we can prevent cancer. Many of you know both my mother and my father passed away from cancer, and I'm a 3-time breast cancer survivor, so cancer is very personal to me, and I too am driven to prevent it. Next slide, please. So, next slide, please. I just want to briefly show some of my disclosures, and as was stated, none of these pose a conflict with what I'm going to talk about. Next slide, please. So I hope many of you are familiar with the National HPV Vaccination Roundtable. They have some superb materials for multiple levels, healthcare systems, providers, parents, patients, that will really help you in your efforts to promote HPV vaccination. And I'm going to share some of them today as I speak to you. So we're going to start, first of all, in terms of why. Why is HPV vaccination important? Next slide, please. So everybody needs to understand that HPV is a public health problem. Why? Because it is a common infection. 80%, or 4 out of 5 people in their lifetime, will have been infected with HPV at least once. These are sexually active people. And about 14 million people are affected with HPV each year, and that includes teens. Next slide, please. Cervical cancer affects both men and women. And hopefully, yeah, there we go. You can see in this picture that HPV is responsible for cervical cancer and cervical cancer precursors, which we'll see a little bit more about the burden of that in our society, but also responsible for oropharyngeal cancer, anal cancer, vulvar and vaginal cancer, and penile cancer. Next slide. So as that figure showed, HPV causes 6 cancers. It is linked with 90% of cervical and anal cancers, 60% of penile cancers, and 70% of vulvar, vaginal, and oropharynx cancer. So HPV really is responsible for a large number of cancers. Next slide. And as I hinted before, HPV really has multiple impacts on population health. So all of those 6 cancers add up to about almost 35,000 cancers. But let's talk about some of the other things that HPV causes, which actually are more numerous. For example, about 300,000 cases of high-grade cervical dysplasia where women have to get treated. Not a simple treatment a lot of times. 355,000 cases of genital warts, over 1 million low-grade cases of low-grade cervical dysplasia, and 2+ million abnormal pap smears for cervical cancer. That's a huge burden, and a huge burden in our healthcare system that we don't always talk about these other things, but HPV really has multiple impacts on population health. Next slide, please. So let's now switch to look at what the national recommendations are for the HPV vaccine. Next slide, please. We'll start with the ACIP HPV vaccination recommendation, which is that routine HPV vaccination be given at age 11 or 12 years. However, and very importantly, vaccination can be given starting at age 9. And I'll get back to that toward the end of my talk, that it can be done, and it can be done very successfully. For persons initiating vaccination before their 15th birthday, the recommended immunization schedule is 2 doses of the HPV vaccine, with the second dose being administered 6 to 12 months after the first dose. So it could be done at annual physicals. Next slide, please. Now, the recommendation is also given to vaccinate males and females up to age 26. And catch-up vaccination is not recommended, but it is allowed, different words here, for those over age 26 with shared clinical decision-making. And it is recommended for some adults age 27 through 45 who are not adequately vaccinated. Again, with a shared decision-making interaction where the physician or the provider and the patient talk about the risks and the benefit, and there is a shared decision made. I should also remind everybody that after starting at age 15, the recommendation is for 3 doses to be fully vaccinated. Next slide, please. So those are the recommendations. Now let's talk about what evidence we have that HPV vaccination works. Next slide, please. So the first is a study that was reported in 2019 where it was shown that we have seen dramatic decreases in high-grade cervical lesions in the United States among women. And you can see the orangey yellow bars in the first 2 columns. Those are the youngest age groups who would have been able to have the vaccine. And we see drastic reductions in the incidence of these high-grade cervical lesions The dark bar represents 2008 and the lighter bar 2016. Thus, the impact of the vaccine is shown in the two youngest age groups who would have been eligible to get the vaccine starting in 2006 and not evident in the older age groups. And then we have further evidence, the next slide, on a paper that was published by Chakravarti et al., showing that the prevalence of oral HPV strains 6, 11, 16, and 18 was significantly reduced in vaccinated versus unvaccinated individuals, and actually was 88% lower. And this is with at least one HPV vaccine dose, as was reported in the paper. Next slide. This next study demonstrated that vaccination was significantly more effective against cervical precancers when the vaccine was given at younger ages. And you can see age is in the first column there, and effectiveness against high-grade lesions is in the second column. And you can see again, the effectiveness was highest when the vaccine was given at age 12 to 13, which is the original age that the vaccine was recommended. You might be asking why. A couple of reasons have been given. One is that to be the most effective, the vaccine should be given before sexual activity begins. And second, that our immune system seems to be much better when we are younger and can actually mount a very nice immune response. Next slide. Well, how about cancer? So we've been talking about pre-cancer. How about cancer? Well, this was a study that was done in Finland, and they found that there were zero cases of HPV-related cancers among vaccinated women in Finland. So you can see the different HPV-related cancers: cervical, vulvar, oropharyngeal, and then all together. And there were none in the vaccinated versus several in the non-vaccinated women. Next slide. So what can we prevent then? What about cervical cancer? Cervical cancer preventable, and it is. Cervical cancer was one of the leading causes of cancer deaths among women in the United States. These are new cancers in the green, deaths in the black. But over 90% of cervical cancers can be prevented with the HPV vaccine. So just think about that for a minute. Next slide, and let's expand that. We can prevent cervical cancer. What impact will it make if we can prevent the other cancers? And it's been estimated that we could prevent over 30,000 cancers each year by HPV vaccination. I don't know about you, but to me, that's a lot. 30,000 is a whole lot of people who won't have to hear those words, "You have cancer." Next slide, please. Well, so we've talked about that it's effective. Now, let's talk about its safety profile. So over 100 million doses of the vaccine have been distributed in the US since it was licensed in 2006. And near real-time data monitoring continues by the CDC that shows the vaccine is safe and effective. And if you want to read more, when you get the slides, you can go to this link and you can read more about the safety profile. Next slide, please. So I was asked to talk a little bit about the current status of the HPV vaccine, because we know it's safe and it's effective. So is it being used? Well, before the COVID pandemic, 54% of teens aged 13 to 17 were up to date. So my abbreviation, UTD, up to date, with HPV vaccination series. And before the pandemic, those more likely to be vaccinated tended to be girls, because girls were approved to be vaccinated clear back at the beginning, 2006. And for boys, it was kind of added in. So the boys were sort of a later group that got approved. Non-white adolescents and those on Medicaid. Now, after the COVID pandemic that we've been going through, estimates suggest that the vaccination rates dropped 75%. And those less likely to be vaccinated were the opposite of what we see above. The minorities, underserved populations. So we've got a little flip here. And some reasons for decline have been given in a recent paper that I found online by Ryan et al. And they put them in 3 buckets. The first is decreased opportunities for vaccination due to reductions in routine care visits. And why were there reductions in routine care visits? We all know this very well. Fear of COVID-19 exposure by going out, by going to a healthcare provider office, and also safety. There were COVID-19 protocols implemented in many of our settings, which reduced the ability to do routine care visits, and B, the interest in anybody coming to our facilities for a routine care visit. The second bucket is disruptions in implementing interventions to increase the uptake of HPV vaccination. There were some successful interventions that had been implemented in a lot of these clinics, but because of COVID, due to either logistical challenges, meaning that there wasn't enough staff in the facility to see the patients, administer those vaccines, or shifts in priorities in that we are focusing on COVID right now. We have got to take care of our sick patients. We are focusing on COVID vaccination now. We can't give other vaccines that we saw a reduction. So these are some of the reasons. And there's a question, are changes in healthcare delivery, we have more telehealth, are these going to be permanent? And what are the implications for this on the delivery of services that need the patient to be in the office, like vaccination? Are these changes permanent for a large majority of our patients who need to be seen in the clinic and who fall into our underserved and minority populations? Next slide, please. I want to share with you just a few things kind of in the last part of my presentation on what we're doing at Ohio State in relation to promoting HPV vaccination. And the first I want to mention is being done by our colleagues at Nationwide Children's Hospital. And they've actually been doing this for several years as part of their clinical operation, which is they recommend vaccination at age 9. They recommend it with a strong, very strongly, which is actually one of the interventions that is very, very successful. Presumptive recommendation, where you say to the parent, your child needs three vaccines today: Tdap, HPV, and meningococcal. Can I give them now? Do you have any questions? Rather than, oh, your child is required to have 2 for school, Tdap, meningococcal, and oh, by the way, there's this new vaccine you could consider getting. So can you see the difference in the strong versus the not strong recommendation for HPV? And if you remember, when did I say HPV vaccine was approved? 2006. That's not so new anymore. So we've got to get out of the habit of saying that and make this strong recommendation. And the clinicians nationwide actually found very good uptake by the parents when they suggested that the child get vaccinated at age 9. And if you know some of the misconceptions about HPV vaccination is that, when it first came out, or what we hear a lot is, oh, that's related to sexual activity. My child's not sexually active. That is, both of those are wrong assumptions that you need the vaccine because you're sexually active. No, or the vaccine gives you a green light to become sexually active. Both of those are not true. But at age 9, that's not sort of in the vocabulary, talking with the child or talking about the child. And so the parents are very much more likely to agree to that. So I just want to mention that and really put that in your radar to start implementing that. The American Cancer Society is also now strongly recommending at age 9 also, I believe. And so there's good reason for that. And it is approved. So then I'll talk a little bit about what the research that my team and I are doing. So we do see higher rates of cervical cancer in Appalachia. We've been working with our communities and our health systems and health centers in Appalachia for almost 20 years now, looking at why there are higher rates of cervical cancer in Appalachia. And we also have demonstrated there are high rates of high-risk HPV, but there is lower uptake of HPV vaccination. So we tested an intervention called iVaccinate, proved effective, and now we are implementing that intervention in a project called Take Care. And we are using, as I said, evidence-based interventions, not only iVaccinate, but the presumptive recommendation. And we are implementing this across 4 states. And we focus on multiple levels of implementation: the clinic, the provider, and the patient level. And we are teaching health systems, we are teaching health centers how to implement these evidence-based recommendations of increasing HPV vaccination. So I'm just going to show you 3 slides so you can see some of the materials that we're using. Next slide, please. So this is something we give to the clinics. They can choose what they want to use. That's what's so nice about this. It's what works best for you and your patients. And so these are some of the things they can choose from. They can post custom posters and fact sheets. The customization is they can put their clinic or health system logo, phone number, etc. They can use follow-up reminder systems in their EHR. And what is mandatory is that they attend a training by our project staff that we now give online via Zoom. Next slide. And for providers, they attend this educational presentation and they do pre-post online surveys. We provide them with a handout tip sheet where they can reframe the conversation about HPV vaccination, similar to what I gave you the scenario, and also very short responses to common questions that parents and patients might ask. We teach them how to discuss HPV vaccination with all age-eligible patients. We teach them how to do the shared decision-making with their older patients. We give feedback on their vaccination rates, and we provide a booster session again by Zoom at 6 months. And they are free to display this iVaccinate button that you can see there. Next slide. And then for our outreach to the parents or the patients that the health systems can do, we provide information about HPV vaccine that they can use in person, via mail, so they can put it in letters. We have reminder magnets. They can use reminders for when the next shot is due. We have a great iVaccinate brochure that I'll show you on the next slide that really hits all the salient points. It was developed with very in-depth interviews with parents, etc. The phone number to call the clinic and a phone call reminder for the follow-up shots as needed. Next slide. All right, this is my last slide, and I want to summarize. There's the brochure I talked about. And again, this one was developed with community input. So what we've talked about is that HPV is a preventable cause of 6 cancers. The vaccine is safe and effective. There is a lot of data to prove that. Children can be vaccinated starting at age 9. And if the person is 15 or older, they require 3 doses. Below that, 2 doses. Age 27 to 45 should have shared decision-making discussion with provider to make sure that they know the risks and benefits and make the decision together if they should be vaccinated. A 75% reduction in HPV vaccination was experienced during the pandemic. We talked about some reasons for that. Catch-up is possible, but it's going to need innovative solutions that fit within the new operating schema that we now have as a result of COVID. And these changes probably are long lasting. So we need to ask, decide, and implement new ways to answer the question, how can HPV vaccination fit into our new clinic operations? And I do believe that this is our challenge because we have something that can prevent up to 6 cancers. We're just not doing it. We're just not implementing it. And I do believe that is a terrible shame. As I stated early on, I'm a cancer survivor. My mother had 4 cancers. My father died of colon cancer. And I think we need to do all that we can so that other people don't have to suffer from cancers that are within our ability to prevent. So thank you very much. I'd be happy to answer questions if there is time.
Thank you so much, Dr. Paskett. Thank you so much for all this amazing information, and thank you for issuing the challenge to all of us to do better. I think that we might have a minute or two, but I'm not seeing any questions in the chat. If anyone does have a question, please feel free, or if at any time during the presentation you think back to a question, we will get back with presenters after the fact and see have any questions answered after our presentation if necessary. So please, feel free to add things to the chat as we go through this entire presentation. And again, thank you one more time to Dr. Paskett. I know that she's joining us from the road today, so it's extra special to have her with us today. So coming up next, we're going to talk a little bit about some of our partners who are doing some amazing things in actually meeting the challenge that Dr. Paskett has issued to all of us. So our first speaker sharing an innovative program to increase HPV vaccination is Elaine Darling. Elaine is a senior program director at the Center for Rural Health Development Incorporated, where she co-manages the center's newest program, Wild, Wonderful, and Healthy West Virginia, and provides supervision to the West Virginia Immunization Network. She has over a decade of experience in immunization and has previous experience in substance abuse prevention and HIV/AIDS education. Elaine also served as a community health facilitator for the U.S. Peace Corps in the South Pacific for several years. She holds a master's degree in public health from WVU and a bachelor's degree from Kent State University. Welcome, Elaine.
Thank you. Good morning, everybody. Thanks for having me today. Appreciate it. Can we move on to the first slide? You can skip that one. Thanks. Go ahead, next slide, please. Well, thank you for having me. I'm here with the Center for Rural Health Development. And just as a quick overview of our organization, our mission is to improve the health of West Virginians and strengthen West Virginia's healthcare delivery system, especially in rural communities. We have a couple of programs at the center, next slide, please, that meet this twofold mission. One of the programs that I'm going to talk about today is the West Virginia Immunization Network. Next slide, please. And the work that we've done with our partners in the state. So the West Virginia Immunization Network is a statewide coalition of over 400 members from the public and private sectors that envision a future in which all West Virginians, from the newly born to adolescents to seniors, are protected from vaccine preventable diseases. Next slide, please. So this is, I think the top of it's cut off, but this is a slide of our adolescent vaccination rates in West Virginia. As I mentioned, we focus on vaccinations across the lifespan, but one of the vaccines that we focus on very heavily is HPV vaccination. I think it's just the toolbar from the top of whoever is sharing the screen is just covering it up. But anyhow, this is our data, our state data for West Virginia, pulled from the Teen Vax View website. So it shows adolescent vaccination rates for teens 13 to 17 years of age in West Virginia. So you can see in the top two lines, the blue and the green lines, are our meningococcal and Tdap vaccination rates, the two vaccines that are recommended at the same time as HPV vaccination. We do really well in vaccinating for those two vaccines in West Virginia. They're required for school. So we have high vaccination rates for those two particular vaccines, but for the non-required vaccines, unfortunately, we have relatively low vaccination rates. Only about a little over half of females and males in West Virginia have started the HPV vaccination series, and less than half have completed the vaccine series. So it does represent you can see obviously the missed opportunities here to go back to some of Dr. Paskett's points. But next slide, please. Thanks. So to address the low HPV vaccination rates in West Virginia, we do a number of things. We've focused on patient education by developing materials for use in health departments, clinics, and schools throughout our state, also using earned and paid media. And then we also conduct regular training opportunities on vaccination related issues in general, but specific to HPV vaccination, we've conducted training opportunities on evidence-based strategies to improve HPV vaccination rates, including using standing orders, reminder recall, avoiding missed opportunities, utilizing motivational interviewing. And most recently, next slide, please. Within the last couple of years, we've focused on providing training opportunities for dental providers in the state of West Virginia. In 2018, the American Dental Society released a statement urging dentists to support the use and administration of HPV vaccine, recognizing that it's a way to prevent infection with the types of HPV that are also associated with oropharyngeal cancer. And so several of our partners in the state, specifically Shauna Schaefer and Michelle Chappell, who are with the American Cancer Society, recognize that the HPV vaccine is the timing of the vaccine falls in line with the timing of routine dental exams. And so they suggested that we start providing these training opportunities for dentists and dental hygienists around the state. So our view was that if dental providers begin talking about HPV vaccine and recommending it to their patients, they really have a great opportunity to be able to do so, because the oral cancer exam that they provide in dental appointments really opens the door for patient education about tobacco use, HPV, and HPV vaccination, and also gives an opportunity to discuss HPV vaccination in terms of cancer prevention. So it adds another voice to the recommendations that are being made by healthcare providers in our state. And so we decided that this would be a great opportunity to work with dental providers throughout our state and bring this training to them. Next slide, please. So we began conducting regional continuing education opportunities for healthcare providers on HPV attributable precancers, cancers, and vaccination. And we developed half-day trainings that featured an oral pathologist who's also the former state dentist for West Virginia. He's trained many of the dentists throughout the state and is very well known in West Virginia and nationwide. And truthfully, dentists and dental hygienists really are willing to travel across the state to hear him present. So he would provide the first session in our trainings, and he provided a session on reflections on HPV infection, cancer precancer and new technologies for early detection. So he really focused on oral manifestations of HPV. And then in the second session, we have a pediatric infectious disease specialist who's also very well known in West Virginia. And she provided a modified version of the "You Are the Key to HPV Cancer Prevention." Next slide, please. The trainings were conducted in partnership with American Cancer Society, the West Virginia Oral Health Program, Mountains of Hope Cancer Coalition, the Marshall University Oral Health Program, and local dental societies. And so all of these partners had a role in helping to plan the trainings, but also to promote them to their members. The West Virginia Oral Health Coalition also shared it with their members, as did the Dental Society or Dental Association. And we were unsure initially about how the training would be received from dentists, if they'd be interested in it. So for the very first training, we held the HPV sessions in the morning, and then in the afternoon held required trainings on opioid and tobacco use. Those are training required CE that dentists need to complete in West Virginia. And so we use that as a way to try to get more individuals to that training. But as it turns out, they were very interested in HPV sessions and learning more about HPV vaccination. And we actually didn't need to have that required training in the afternoon to get people to the trainings. So all of the subsequent trainings were held in conjunction with local dental society meetings. And really that evolved because once some of them attended that first training, they started asking if we would come and give those trainings at their local dental societies. And so what we would do moving on from there was hold the HPV trainings in conjunction with their regular meetings, but ask that we could invite dentists and dental hygienists who are not members of their dental association to attend the trainings as well. And so we got really good turnout from the individuals that were members of the local dental societies, as well as from many others in the area who were not necessarily part of those dental societies. Next slide, please. And so to date, we've trained 302 dentists, dental hygienists, and dental assistants through 5 different trainings that have been conducted throughout West Virginia. We've also conducted additional sessions at the State Dental Association conference. However, I will say, I think the trainings seem to go better when they're held in conjunction with the local dental societies, because we can hold longer trainings and be able to have both of those presenters speaking, versus when it's at the State Dental Association conference, it's really just an hour, maybe an hour and 15-minute presentation. So we can't get quite as much information in those sessions, but it is a nice opportunity to still engage with dentists and dental hygienists who have not attended the regional HPV conferences. But in a follow-up survey, a year after we conducted the regional trainings, 87% of the oral health providers reported that they do recommend HPV vaccination to their adolescent and young adult patients for cancer prevention. And we did have some dental providers that are at FQHCs or community health centers that reported that they ask about HPV vaccination status. And if the patients are in the age indicated for vaccination, but have not yet been vaccinated, they refer the unvaccinated patients to another area of the FQHC for vaccination that same day following their dental appointment. So it's a really fantastic way to refer to treatment, but while they're still in, or refer for vaccination, but while they're still at the community health center. And again, that's anecdotal, so I don't know how frequently that's occurring across all of the community health centers, but we have heard that reported from some of the dental providers that have attended our trainings. Next slide, please. So we've also developed some materials for the dentists and dental hygienists to use in their clinics when educating patients about oral cancer and HPV. So you can see that brochure on the left. And then most recently, we've developed several other new materials for broad use across dental clinics, as well as community health centers, school-based health clinics, private healthcare provider offices, and local health departments. Next slide, please. And so that's essentially a summary of what we've done with the, in terms of the trainings for dental providers in West Virginia. As I mentioned, we've had great response from them, and we have conducted those. We did take a pause at the start of the pandemic due to the limitations on in-person trainings, but we did start those up again last year, and there's still a great deal of interest from the dental providers in our state for that training and to continue to recommend and promote HPV vaccination to their patients. So I don't know if you wanted for me to take questions now or at the end of the whole panel.
We're actually going to hold till the end of the whole panel, but just real quickly, there is one question in here that since we have a couple minutes right now, there's a question as to whether, do you happen to know if it's true that some states allow dental providers to administer vaccines and some do not?
I think there's 1 or 2 states that do allow dental providers to administer vaccine, but West Virginia is not one of them at this time.
Great. Well, thank you so much for all the information, Elaine. I think that everyone found that really interesting. And I just love the work that's happening in West Virginia, and what a creative way to kind of look at the schedule, vaccination schedule, and make that happen for people of West Virginia. So thank you so much. Up next, we have Dr. Adam Keating. So he's going to be our next speaker on the panel. Dr. Keating is a general pediatrician and section head at Cleveland Clinic Worcester. He is the quality improvement officer for ambulatory pediatrics at the Cleveland Clinic. His academic appointments include assistant professor of pediatrics at the Cleveland Clinic Lerner College of Medicine and associate professor of pediatrics at Ohio University Heritage College of Medicine. Please welcome Dr. Keating.
Thank you very much. It's a pleasure to be here today, and I've really enjoyed the presentations so far. You will see some themes that are repeated in my presentation as well, but that's great because we know repetition adds to learning for all of us. And I'm a pleasure. I'm very happy to share what we're doing at Cleveland Clinic Children's. Let me go next slide, please. And this reminds you all what you're here for today. We'll go to the next slide as well. So in the brief time today, we talk about our learning objectives. This is a CME event. I would like to touch on some potential barriers to the vaccinations that currently exist, how, again, our recommendation style may impact the vaccine, and at least 2 of our population health strategies that we're using to help increase our vaccination completion. Next slide. So this really focuses on our vaccination completion rates and what are barriers that are going on. And this is a meta-analysis. It's a little dense of a slide. Don't worry about where the confidence intervals are. You can review those later on. But really what I want you to get out of this is that that factors influencing the uptake include my job as a physician recommendation, addressing any HPV vaccine concerns we have, and importantly, as we had said, the use of preventative checkups and actually getting in to see the doctor, whereas the parents' belief in vaccines certainly plays a role, but is not the only factor that impacts vaccine completion. Next slide. So in a study, and this is now almost 10 years old, of vaccine completion against HPV, this was a survey of the parents' concerns. And you can see they're similar for the concerns of girls and concerns of boys, but not the same, or at least not at the same rate. But that the themes are completed in there, and we can control what we can control, and that not recommended, the lack of knowledge about the vaccine, or the perception that it wasn't needed or necessary are high among those rates of the vaccine. And I think we can all agree that that's a misconception on their part. So, and that if we can prevent cancer, we certainly would like to do so. And helping educate parents is part of our job for those that recommend and counsel about vaccines. Next slide. So there are there are barriers for us of clinicians of being able to recommend vaccines too. And I think it's important to address this because we do have competing priorities at our well visits and our appointments with patients. We certainly have missed opportunities from our adolescents who are not necessarily coming in with their preventative care. We've certainly seen that increase post-COVID, as Dr. Paskett noted in her remarks as well. And there are missed opportunities for our interaction with the adolescents where they come in for non-well care, but we do have the opportunity to catch up on immunizations then. There's good evidence, as Dr. Paskett said as well, too, of a strong recommendation from a provider increases the chances of completing the vaccine. And sometimes providers overestimate parent concerns and either don't want to get into the conversation or weigh on concerns too much rather than the presumptive recommendation. Next slide. So this is, again, a busy chart. The details are not important, but if you look at the blue lines on these, the light blue, that is completed general checkups from the adolescents in this study. The darker gray bars in the middle are visits that happened, but what didn't happen to be a checkup. And then those lighter gray bars are those that didn't make it anyway. And we can see that there's opportunities in all three of these segments of the population. Certainly our priority is making sure that the adolescents get in to see a physician, and then we do our job well to be able to counsel them about HPV vaccine. So we knew that part of these visits is that some of the area children were not making it to us. And so like many others, we've had a school-based health program. We decided that we would bring our services to them in opportunities. So starting in 2014, so we started with our mobile unit. So, and there's a picture of this over to the left here. This is a souped up RV that is essentially 2 exam rooms on wheels. So offering full services of a mobile clinic, including being able to deliver immunizations, do phlebotomy, and have complete connection with our electronic medical record. Post-COVID now, it's also important to say that we also have the capabilities through the mobile unit to do virtual visits on site as well too. And so really to do comprehensive care at the site. We do partner with some local school districts, and we're increasing through K through 12 in those school districts, and even 5 preschools. But certainly one of our target populations is our adolescents who aren't making it to our office. We do have one brick and mortar site as well at one of our local school districts in Lakewood, and you'll see that's been a very well-used site as well. But we know there's significant infrastructure for our school districts to be able to offer a brick and mortar site. And so the mobile unit certainly makes a lot of sense, particularly for our districts that are under-resourced. So we'll go next slide, please. So, and this is just information about the numbers aren't as important as well, but the growth of our school-based health program, including with our mobile units and our Lakewood High School and mobile units. And you can see all the way to the left, the total of patients that we've served are in the thousands. Certainly not all of those were adolescents and not all HPV, but a significant number of opportunities to be able to prevent cancer in kids, to be able to catch them up on their immunizations and their well care in general. Go next slide. So there is the question, well, does this really work? And this is not our data, but a study of a rural health system of using an intervention and control group. And does offering vaccine at the school increased rates of vaccine outside of, perhaps it's just because people were there recommending it to the students, and if we just did an education campaign, would it increase? And as we look at the data, you can see that education campaigns are effective at increasing the vaccine rates. That's the control group with education alone. But if you actually offer the vaccine at the school, that initiation of the first dose and completion of the second dose increases dramatically as well. The next slide, please. So in this really of looking at, again, 2008 through 2013, a little bit, this is missed opportunities. So this was girls at the time because of who was eligible for the vaccine, but that's who received it before age 13. If we had had no missed opportunities, so they had interaction with the healthcare system, and at every interaction with the healthcare system, we gave the vaccine, then we certainly could almost double the rate of the vaccine. So that's just the reminder to us that when we see someone, so we should be reviewing their vaccination status and updating at every opportunity that we have. Go next slide. So our other population health strategy is to be able to put this top of mind for our providers. These are 3 different population health records that fit at the point of care for our providers at this time. So during our use of our electronic health record, we do have this health maintenance alert that will tell of vaccines and screenings that are available and pop up, so at the time of the visit, and so that all members of our healthcare team can be able to see that. We do have some analytics and dashboards to be able to target a population for outreach. As we say in our population health work, we are increasingly not only responsible for those patients that we see, but also those patients that we don't, that are attributed to us. And so we did build a tool not only for those that are due for HPV vaccine, but as we look at, this happens to be my personal panel, that I have 27 patients ages 11 to 12 who have received 1 dose of the HPV vaccine so far, but haven't gotten their second. And that's certainly an easier ask to be able to just get them into the office, that we've already done the counseling and shared decision making. So an easy outreach to be able to complete that series. And then we track as a population among our group of what are immunization rates. And we can see we have significant completion of our adolescent combo 1, which includes the Tdap and Menactra. And as we've said, that HPV vaccine really is down at that 41%. So of our combo 2, where Dr. Paskett has talked about the relative dichotomy at 11 years old of those required and quote unquote non-required vaccine, that frankly makes our job harder. Go next slide. So I've done these 2 slides. This was one back of pre-pandemic and post-pandemic, but I like the very non-scientific thing sometimes of knowing what people are concerned about. And so Google's a good tool for that, to be able to string match. And if we just type a thing, its algorithm will say, here's the most common things that cause afterwards. And so there are concerns listed on this that are not among the concerns that I think about with HPV vaccine, in particularly talking about paralysis. That was an initial thing that was coming on, and infertility, those are on there. But now people thinking about blood clots as they're hearing about COVID vaccine and blood clots and misconception about that. And so it has to get into the things that I'm on my radar to be able to talk about with parents. The next slide. So, and I won't spend a whole lot of time on this. We all are increasingly aware of the misconceptions and misinformation around vaccines during this time. And HPV used to be the vaccine that people hate. And it's now certainly among that, but not the only vaccine that we need to talk about with misinformation right now. Go next slide. So, and again, simple recommendation that we say to begin the conversation, but a strong recommendation is important from physicians saying that I know there's stories about the safety in vaccine, but I talk about that there aren't serious side effects and that I feel it's safe. And frankly, I tell people that I'm a paid consultant and this is what you're paying me for. And you know, it's part of this recommendation is for me to be able to offer the best advice that I can. So, and certainly, yeah, I hope that I'm better informed about such things rather than, you know, their hairdresser's cousin who heard something on the internet, and we certainly see that sometimes. Next slide, please. So physician communication, as we said, and Dr. Paskett said, that the timeliness, consistency, and urgency of the recommendation changes the rate at which we're able to vaccinate the children that we see. Go next slide. So there is data about the effectiveness of the vaccine and saying that a brief persuasive statement has the highest endorsing. So something as simple as I believe strongly in the importance of this cancer preventing vaccine for your child. And that simply as a recommendation is sometimes all you need to say, certainly addressing questions in shared decision making, but making that presumptive recommendation changes the way in which parents accept this vaccine. Talking about all these things that we had as the data before about the vaccine safety and effectiveness. I did see some questions come up as I was talking to about, is there data around this? And there certainly is. So around the safety and effectiveness of the vaccine. I find some parents really want to know those numbers themselves and link to articles. So, and specifically on infertility, that there's, I think it's a misconception that because HPV can be sexually transmitted, that there's something associated with infertility around that, but that there's not an increased association in infertility with HPV vaccine. There is an increased infertility. So for those with HPV infection, so and particularly around that of needing invasive things like colposcopy after an abnormal pap smear. We'll go next slide. So, you know, if we're recommending at 11 years old, as we said, the simple way to think about it is to make the recommendation in the same way on the same day as the other vaccines. So you are due for Tdap and HPV and meningococcal vaccines today because you're 11. So, and then again, we have many of our providers also introducing HPV vaccine at age 9 as well. And the next slide. So again, just an algorithm about announcement versus conversational, so that here's what you're due for today, and then seeing if there's concerns only if needed, rather than asking about concerns first before the recommendation makes a significant difference in uptake. So just to keep in mind for those of us that are responsible for counseling patients and families or friends and families about this vaccine. And I believe that's my last slide. So thank you very much.
Thank you so much, Dr. Keating. And I think you saw there's some interesting conversation happening in the chat. We have a couple questions that we're going to hold for just a moment.
Right.
But right now we're going to launch our next poll. Dr. Keating mentioned some of the studies with some of the information about what some of the barriers are to receiving HPV vaccination, but we know that everyone here sits, and engages with individuals around HPV vaccination. So we would love to know, what do you observe as the biggest barriers when it comes to HPV vaccination? And feel free to choose, several options if you think that that is the case. And while you're wrapping up your answers, we will go ahead and move on to the next slide, and I will go ahead and introduce Dr. Butch-Kovacic. Dr. Melinda Butch-Kovacic is going to be our last panel speaker today. She is a passionate epidemiologist and community partner public health researcher on a mission to promote health and reduce the burden of cancer among people across the Cincinnati region, particularly under-resourced communities. She has held numerous NIH grants, several of which have focused on understanding the role of human papillomavirus in high-risk populations. Currently, she has 2 NIH R25 grants, one that gives undergraduate researchers opportunities to work in labs and research groups across the cancer continuum and into the community. The other funds her We Engage for Health, which is led by a 20+ member community academic partnership that utilizes community co-designed graphic style stories and engaging learner experiences targeting children through adults to promote health literacy and interest in citizen science and research. Welcome, Dr. Butch-Kovacic.
Thank you very much for inviting me today, and I'm very excited to be able to share our work with you about our graphic style stories. Next. So I started We Engage for Health back in 2018, and we realized that there was a lot of folks in the community that had different learning styles, different educational backgrounds. Their health literacies were different. Sociocultural differences, psychological differences in life experiences, and age-related differences. And we wanted to be able to help promote health better across all these differences. How do we do that? And how do we, specifically relative to this presentation, how do we encourage HPV screening and vaccination, particularly in groups that really don't understand what HPV is, and they just are a little leery of the healthcare community as well. And I have to say, one of my stories is in my community research advisory board, when I brought HPV up to talk about HPV, people didn't know where the cervix was, they didn't understand what HPV was, and they were very alarmed to find out that it was sexually transmitted. So it was something that I realized was a definite need to be able to have that conversation. Next slide. So one of the things that our group has done, and this came from my colleagues at Miami University, they were using stories with middle school and high school students. And we wanted to see if this was something we could use with adults. And so we knew that stories were, something that we all do. We tell stories, and we sometimes tell our personal stories, reflecting on what happened with our parents or with ourselves. We might tell a historical story. Think about the Bible is a telling of stories. We also make up stories, and to teach people things. So stories are a representation of connected events and characters that has had an identifiable structure, and our structure has an arc that includes a problem, an action, and a resolution. They can be shared. These stories can be shared in so many ways, in written and text format. They can be done verbally or orally. We can use them on digital platforms. You can put images with them, or you can just use the story itself. And for our particular approach was using a graphic or comic style story. But these stories are often underutilized in healthcare. Next, please. So one of the really cool things that we really started to dig into why our story is powerful. So we're writing a paper right now called The Power of Stories. And what we figured out was that, we know from observing in the groups that we used our stories in, that people are able to understand things that we wouldn't have expected them to understand. And it opens up a conversation that doesn't normally happen otherwise. So what we figured out was that there is different types of learning styles, and I'm not going to go through all the learning styles, but what I want to say is a lot of times academics use a linear learning style because that's what we use in academia. That's what education systems like to use. But there are plenty of people in this world that are experiential and global learners. And some of those folks, especially those folks with limited health literacy, really benefit from a different approach. And a story approach is really very useful for them. Lots of linear folks like the story approach, but some of that linear folks think, well, why aren't you just giving me the instructions? Or why aren't you just telling me what I need to know? Because they get that. But the other folks, they might have more challenges with that linear approach. And so this is why it's really cool to use in certain populations that have a lot of health literacy issues and to use this other approach. Next slide. So as I said earlier, storytelling is one of the most ancient forms of human expression. People use it, we share stories, and stories are different based on different cultures. So we have religious practices, poetry, songwriting, you name it. It's a really great way to quickly give an insight and get a response and have a discussion. It helps people to increase meaning of what they're hearing and have that discussion. Next slide. And what's really cool is people seem to remember things over time. So this is a slide that's got a lot of stuff on it. I just wanted to share that there's also scientific evidence. There's been fMRI studies and psychological studies showing all the value of stories and how important they are into helping people understand information. We've done a lot of research on whether or not the stories need to be read out loud versus silently, whether or not it's good to read them with others or with just one other person, if it's okay to work in a group. We also have really looked at like the science behind it, like what is the reason why this is working? Because we know that it's working, but how do we kind of describe that? So this slide kind of gives you some of those angles of why stories are really important. Next slide. So Casey mentioned that I'm part of We Engage for Health. This is a science education program award. And the SEPA grants are typically focused on children all the way through adolescence, although our SEPA grant, when we wrote it, was intergenerational. We really wanted to have adults involved because we feel like especially when it comes to healthcare related concepts, you have young children, but they don't get to make the decisions in their lives. So really incorporating some of this with adults. Now, graphic style stories are used across the world. The Simpsons is one of the longest running cartoons on TV. So it's not just about kids when you think about comic style stories. But we didn't know because we had some of our people that were pretty skeptical when we first started. And so we wanted to make sure that adults specifically also would enjoy the stories. And so we have this team of people. We have faculty on the team. We have staff. We have high school interns. Right now, I actually have 3 new undergrad interns. We always have community involvement. We have 6 community members that are regularly participating in our story evaluations. We also bring other people in as needed. And we, of course, have an evaluation services. And we co-design everything. So next slide. So what I mean by co-design is we have this whole series where we work with our community to say, what do we need? And then we kind of come up with some ideas for stories. Some of our stories are 3-panel stories, and I'll show you one of those in a minute. Some of our stories are much longer, depending on how we're going to use them. So for example, a health department can use a 3-panel story very quickly, and a longer story might be used in a program or go into a school where the kids can interact. So what we do is active collaboration. So we go back and forth in many iterations of creating ideas, creating a script for our stories, actually creating the story itself, and then putting it in Comic Life, which is the software we're using to create the stories. And the cool thing about Comic Life is even after we've created the stories, we've tended to go back and alter them based on the needs of the groups that we're working with. So we worked with Santa Maria, which is a Hispanic Latino focused group in Cincinnati, and we needed to make them in Spanish. So we had to alter our story a little bit. Plus, some of the context was a little different when we worked in that group than when we worked in other groups. So again, these are things that we can quickly do in Comic Life and make it very easy to adapt as needed. And that really helps us, with ensuring local and cultural relevance of our stories, and really helping people to learn from a shared experience of others like me. So we really love to promote the stories being led by people in the community, not by us. So we give them resources, we give them training, and they actually use the stories in their work. And what we found is that the people that are actually leading the stories or facilitating the programs that we do really have a great benefit as well. Next slide. So this is our cast of characters, and we had 6 original characters that we started with, and they were designed by the community. And we work with the West End community, which is 93% predominantly African-American community. It's by the whole new soccer stadium, and that's that community that we work with. And we have added characters over time as different groups have needed it. Recently, we're working with a group to offer a health sciences introduction, health sciences to Breakthrough Cincinnati, and we're needing to give our characters different jobs or different backgrounds. And so a lot of the things we do is we use these characters. So when you look across our stories, our backgrounds of each character is consistent with other stories. So for example, Carter is one of our newer characters. He is a faculty member at the local university who does citizen science and health promotion work. And Addie she is probably the newest. She's a little girl with her sister Jazzy has asthma and is a gymnast. And Addie is her little sister who has eczema and is in an eczema study. So we have Vito is our teenager who snacks a lot, but he recently joined the cross country team, and I have a whole slew of stories because I'm a cross country coach. And so we made a whole bunch of stories on how to introduce the sport of cross country and running to young children. Anyway, these are our characters, and we use these in all of our stories. Occasionally we do add new members of the story, but it's harder to add a new member. So we'd like to spin. James is one of our newer characters too. He has autism. So next slide. So our stories are a little unique. We really work on making them, the co-design process helps the community feel ownership of them. They're always fun and engaging. Like I said, they're locally and culturally relevant. They quickly create shared experiences, and they're low stakes, meaning that people don't need to understand science or health to understand them. And what's really, really important is they explain why, rather than simply telling people what to do. You can tell people to get vaccinated, but a lot of our longer stories go into a lot of detail about why you should be vaccinated. So we have a lot of COVID stories right now, and we've gone into a lot of work on explaining why. They also only focus on 3 big ideas. A lot of folks try to, give a lot of information quickly, and people just don't retain a lot of information. So we really focus our stories on 3 big ideas. We want to make sure that people walk away knowing that information. They're designed for informal health programming and all kinds of events. And they're really, really working to make sure that people of all types can understand and that people can have a discussion and make personal connections after they read our stories. Next slide. So this is an example story. This is Monique. She is a mom of the 2 girls. Jazzy is her daughter. That's why in this they look a lot alike, because they're daughter mother. Monique is a breast cancer survivor, and Jazzy is the sassy preteen who is kind of a know-it-all actually. And Monique in this particular story for HPV is talking about the doctor, going to the doctor, and she's introducing the concept of getting the HPV vaccine. And then she says that she's got to get a second one in 6 months. And the little girl, she's like, she was hoping to go somewhere else. She obviously doesn't want to have anything to do with this. And so the mom talks about what HPV stands for. She talks about the fact that there are multiple HPV types, and that you can also get genital warts. I mean, just a lovely conversation that you have with your daughter, right? And then she also brings up that it can also cause cervical and head and neck cancers, for example. Next slide. And these panels, Jazzy claims that she's way too young to be worried about this. And Monique's like, you know, we need to prevent cancer and we don't want you to even get infected. So we're going to get it, you know, now so that you're not going to be infected when you're older. So this kind of shows this interaction, which a lot of parents might have, or parents that should have, who's afraid to have this discussion. And we also have a picture of the fallopian tubes and cervix and vagina. Honestly, we put that on there because our community members, when we were trying to write the story, said, where exactly is the cervix? And so we put that picture on there. We also bring up the Pap test. We didn't bring up the HPV test in this story, but we talked about whether or not we wanted to do that. The story is being currently, this particular story is being currently used at health fairs. So we didn't want to go into too much detail. Again, we don't want to go have more than 3 big ideas. So we even say the test looks for cell changes in my cervix that the HPV virus could have caused. If the test finds these changes, they can be treated. So we try to even explain, you know, that we actually thought about having a little slide of, you know, cells that were, you know, had changes in cells that weren't. We actually still think we might add that. And then at the end, you know, she says, sounds good, you know, let's get going. So no big deal. And it was funny because if you read, well, to escape HPV, it's best to be vaccinated before you're exposed to it. And that's what happens when you have sex. And then that's when she's like, oh my gosh, let's change the subject. That's pretty typical for a kid this age. So next slide. And we would be reading this out loud together. I would be one character and you would be another character, or we would choose characters to read this. So like I said, we always, our fourth panel is always health challenges. You can't read that up there, but there's health challenges and we always have healthy actions. So we kind of highlight what are the health challenges and what some actions they can take. And in this particular case, we do say HPV testing and Pap tests are important screening tests to detect precancers and cancer. Like I said, I've used this particular story already at health fairs. We're going to have another health fair in Norwood that's going to have the whole room is going to be these stories, so you can come check it out. But our goal is to have our group there kind of lead a discussion after the people that come to the table read it out loud together. And then we often give away items or even have a game. So, you know, for younger kids, hands-on games, but even the older people like the games. So really engaging them and encourage them. And then we have a document that we're giving them to ask them to commit to some changes. So for example, committing to having an HPV test and or screen. And then also giving the recommendations too. So our document that they walk away with basically asks them to commit to something. Next slide. So I use graphic style stories, but graphic style stories is not the only story type approach. Minjin Kim is here at UC's College of Nursing, and she's got one of our KL2 awards. And she's doing a study where she's going to use storytelling along with artificial intelligence, chatbot technology. And she's really trying to target HPV vaccination in Korean American men and women. Because, you know, a lot of folks don't necessarily want to talk about this, but engaging with an app or a digital device is something that people will do. So this is what Minjim's doing. Linda Larkey is at Arizona State University, and she has also been partnering with Vietnamese parents, most of these being immigrants, and she uses a digital storytelling approach to encourage them to vaccinate their children. So she had a meeting with them over 2 days and helped them tell their personal stories, recorded all that, and they created these digital stories. And then they share these digital stories with parents and then figure out if they will intend to be vaccinated. And then I think the next part is to see if they actually are vaccinated. But this is, again, she's using this in a population that isn't necessarily very excited about going to the physician, and really trying to help people understand why some parents make that decision. Another group in University of California, UCLA, used narrative film. And this is an older, I think this was in 2016, but they still use this narrative film to provide more information about HPV and prevention. And so they use a storyline around Lupita, a young woman recently diagnosed with HPV. and she's informing her family about HPV and the availability of the vaccine. And they've done several studies looking at this particular story in different racial and ethnic groups to see, does this impact all those different groups? And they've had a lot of success with the stories. So stories are a great approach, and health departments can use stories just as easily as people like me who are in the community at a community engaged research, because we actually have stories. We're working with the Cincinnati Health Department and the Norwood Health Department around COVID to offer these stories, and then we have a whole program where we're teaching people how to use the stories to kind of initiate those conversations. And I think that's it. Next slide. I have a picture I wanted to show you guys. We have our little purple t-shirt, so you can see that, but we do a lot of community groups and the community research advisory boards at the bottom. And these are the folks that when I first went to them about HPV, and they were very confused about what HPV is. And I'm pulling up pictures of prostates and cervices. It was really funny because I have no problem talking about this stuff, right? And they were like, oh my gosh, but they got over it and they learned a lot. And now a lot of them are our advocates for the work that we're doing, and they joined up with We Engage for Health. And you can see some of our games and stuff that we play. We always have to, of course. So I'm happy to talk about to anybody who's interested in creating a story or using one of our stories. It's just a lot of fun and it's very useful. So with that, I'm going to end.
Thank you so much, Dr. Butch-Kovacic. I just absolutely love this. I love how you're engaging the community, and it is such an amazing way to get such an important message out. We now have some time for a few questions, and I just kind of want to circle back. If you do have any other questions, please feel free to put those in the chat. But one of the questions that came up earlier, I wanted to bring back to the group, and anyone from the panel can answer it, is it seems that there's a lot of concern around parental concerns with infertility. So just wondering if we can circle back and address that maybe, and maybe are there any specific studies that you might refer back to, any specific data or information that you would share with a parent who is particularly concerned about later effects of the HPV vaccination around infertility?
Sure, I can take that. So yes, there have been concern about something called premature ovarian failure, which is early menopause or infertility with HPV vaccines. Most recent study, and I was doing a little bit of looking around while we were talking here, there is a question and answer session specific to this on our CDC's page. And links to studies and a meta-analysis done in 2020 around this did not show an increased risk of premature ovarian failure around the studies. I'm happy to put a link to that in either the chat or the Q&A, whichever works better.
That would be great. And I don't know if, Elaine, if you had a question at one point or a comment that you wanted to share? Elaine, I know, has a tight timeline now.
So I did have a question for Dr. Keating. One of your slides mentioned the slicer-dicer component. It was the gap outreach slide. What is that?
So slicer-dicer is an EPIC product that allows us to do some on-the-spot data analysis and crunching. So it's not, it means we don't need to involve our data analytics team. We can say, for that particular one, I said, show me a list of my patients who've had at least one HPV vaccine, who have an active alert for a second HPV vaccine. So, and it can create a report for me.
Thank you.
And there's a lot of really great conversation that's happening in the chat. One comment that I see is that the intergenerational strategy is used by Disney in order to get parents and guardians to watch and attend their movies as well. So they base it on the ROI of catalyzing parents and guardians to pay for and or seek out Disney animated movies because they are appealing to an intergenerational audience. So, you know, HPV vaccination, Disney movies, it's all the same at base, I guess. Any other questions before we move on? And I thank you all to these. I am just so excited about these really amazing ideas. I love seeing some really great minds using their creativity to meet Dr. Paskett's challenge of increasing HPV vaccinations. So thank you to all of you. And up next, we would like to share a brief message from Dr. Adrienne Dorrance and some of our other Goal Together champions about some of the work the American Cancer Society is doing in pediatric cancer through our Goal Together campaign. So let's see if we can make our video work.
Hi, my name is Sarah Morris. On February 12th, 2008, I was 17 and heard the words, "You have cancer," being diagnosed with acute myeloid leukemia. That is why I am passionate about the American Cancer Society's Goal Together campaign and have chosen to be a candidate to raise funds for this very important cause.
Hi, my name is Adrienne Dorrance. I work at The Ohio State University's Comprehensive Cancer Center, where my lab is investigating new targets to treat acute leukemia, but also ways to improve bone marrow transplant therapies for children with blood stem cell disorders. On average, 200 children are diagnosed with cancer every week in the US, and we desperately need better treatments for these kids. All funds raised by the ACS directly support childhood cancer research. This includes the work we are doing in my lab here at OSU, but it also supports cancer prevention efforts to lower children's risk for cancer later in life.
Hello, my name is Kristen Brown, and I am passionate about supporting the American Cancer Society's Goal Together campaign. In 2021, approximately 2,000 children under the age of 15 are expected to die from cancer. As a survivor of a rare congenital brain tumor, I am asking you to help me in the American Cancer Society Goal Together campaign this September. All funds raised through Goal Together support programs of childhood cancer, research, support services, and awareness, as well as cancer prevention efforts targeting children. By working together, we will have more of an impact, more options for care, and better outcomes. I hope you can support me. I hope to see you this fall.
I support ACS's Goal Together campaign in the month of September because I am determined to help find a cure for all pediatric cancers so that no parent has to hear that their child will die of cancer. I do this in memory of my nephew, Asher, who was a victim of ependymoma, a pediatric brain cancer. Asher succumbed to the disease in 2013 at the age of just 4, after fighting through chemo, radiation, and multiple surgeries for over a year and a half of his short life. I loved Asher. He had a kind heart and a beautiful soul, and I will always miss him. And so I continue to fight on for him and for all children to find a cure. ACS's Goal Together campaign is an important component of that fight. And so I hope you'll join me in supporting this campaign.
And we really hope that you'll take a moment to check out our Goal Together campaign we're launching at the end of the summer and join us in the fight against pediatric cancers. And now we'd like to take the opportunity to share some of the work being done by payers locally and nationally in our 2022 HPV Vaccination Learning Collaborative. And it might take us just a minute to kind of transition over here, because we're going to have to switch screens quickly.
Good morning. Thank you so much. My name is Katie Crawford. I am the Senior Payer Engagement Manager with the American Cancer Society. Thank you so much for inviting me to share a little bit about our HPV Learning Collaborative with health plans. I'm very excited to share this information. All right, so how does ACS work with health plans to increase HPV vaccination? One, we are working on a learning collaborative with health plans. Two, we engage national partners for joint action like NCQA, AIM, AHIP. So any of our national partners that we can engage, we certainly do. And then 3, we really work to build ACS infrastructure and staff capacity. So that's what I'm here for. I help with trainings, making sure that staff feel comfortable working with health plans, and provide any technical assistance that I might. So in 2021, we had the opportunity to host a very small pilot learning collaborative with health plans to really test the waters and see how it went. We had 5 health plans over 7 states that participated, both private and Medicaid lines of service. They represented about 15,000 active 13-year-olds in that cohort, and 4 of the 5 were linked to an integrated delivery network. We had a lot of success with that program. We were really excited with the engagement from the health plan, so we decided to go ahead and spearhead another cohort this year, and it's turned out to be a much larger project. Our partners touch over 20 states throughout the country. You can tell here from the map, we have various lines of service, commercial, exchange, Medicaid, and a few CHIP plans. These partners reach over 17 million members nationwide. And in the cohort, they have over 205,000 active 13-year-olds in their membership base. We have 41 various product lines participating. We have some national plans that are participating with both their Medicaid lines of service and their commercial and some of their exchange lines as well. So some of the really exciting news is 7 of our partners had not prioritized the adolescent immunization measure at all. So this is the first time that they've really addressed HPV in a very quality improvement manner. And 22 of our partners are focusing on vaccinating at ages 9 and 10. So here at the American Cancer Society, we understand that starting the HPV vaccine series at age 9 has a lot of benefit. It really reduces the amount of shots that you get at that 11 and 12-year-old visit. You can really start that conversation earlier. You can avoid a sexual health sort of conversation with parents. And we understand that starting the vaccine at age 9, your child will produce more antibodies. So it's very efficacious to start early. So some of our data showed that our plans had about a 60% initiation rate, but only about a 30% completion rate. So we've got a long way to go. As you can tell, they're doing quite well with meninge and Tdap, but that HPV completion rate is really dragging down their overall IMA measure. So it's really important that they separate that vaccine out from the others and are very intentional with recommendations, with member reminders, with really working to increase the vaccine compliance with HPV. So a little bit, let me go back one, sorry about that. One of the very interesting finds, and this is really sort of a change from pre-pandemic. So pre-pandemic, we often saw that Medicaid lines of service had a better initiation completion rate. Post-pandemic, according to our information, it looks like commercial plans are actually doing a little bit better. So some of the really key interesting finds that we have uncovered from this project so far is 4 of our partners weren't even talking about HPV vaccine as cancer prevention. So that's really low-hanging fruit. We can arm them with all the materials that they need to make sure that they are delivering that cancer prevention message when they're talking about this vaccine. Over 80% do already tease out HPV in their member reminders, which is great. 80% indicated that IMA is included in their quality metrics with systems and providers. However, only a little over 50% are tied to payment for providers. So that offers us another opportunity in figuring out how do we engage providers and incentivize providers when it's not a metric that's tied to payment. So over 60% of our partners intend on offering some specific provider education, really starting at age 9. And at the start of our project, only about half the partners were including both a quality improvement staff partner and a provider relations staff partner on their HPV vaccine team. As the project has gone along, we're seeing them really engage both of those roles in this effort. So that's wonderful. And then just a quick overview of the top provider and member EBIs that they're working on: provider outreach, education, recognition, incentives, assessment and feedback. reminders and standing orders. In terms of members, member reminders, education, incentives, there's a lot of intentionality around social media outreach, and then also really working to optimize their member portal right now, which is great. So some of the call topics that we're going over with our partners are using data. How can they review their data, really look at that initiation rate, which isn't something that we have seen health plans do in the past. They really look at the completion rate, and reviewing those missed opportunities. Starting at age 9 is a theme through the entire project. And then member and provider focused interventions. We had a great call this last week with the co-chairs of the HPV Roundtable, and they were so helpful in talking us through some really impactful provider and member focused interventions. And then combating vaccine misinformation and how health plans can play a role in making sure that they have accurate and educational information available to their members and to their providers. Provider recognition, assessment, and feedback. We're going to hear a lot from our partners about how they implement those EBIs into their plan projects, and then implementing quality improvement at the practice level. So that was a lot. I hope that you guys have a wonderful day. Thank you so much for inviting me. If you do have any questions, please reach out to your American Cancer Society Strategic Partnership Manager. I'm sure that they'd be happy to talk to you. We'd love to have more health plans engaged in the years to come. We do anticipate doing another round of learning collaboratives in the future. But thank you so much. Have a great day. Take care.
Thanks to Katie for sharing that amazing information and some of the amazing work that she's doing. And now I think it's time for our final poll question. So we'll have that pop up here in a moment. And what the question is going to ask is, based on the observations among those who you serve, which population groups face the greatest barriers to HPV vaccination? And again, this is a poll where you are welcome to choose any or all that apply from your experience. The other thing that we'll share, if there's a group that we missed here, or if there's a particular barrier that you feel that we missed on the last poll question, feel free to pop that in the chat. We would love to hear. We know that when we're doing a multiple choice question, that we are kind of missing some subtlety and some of the finer points here, but we would love to get some feedback on what's your experience with providing HPV vaccination. We'll wait for a few more people to submit the question. We're about half of our participants have shared information. All right, thank you so much for sharing your input. So our final presenter is going to be Christina Turpin. Christina is the director for the National HPV Vaccination Roundtable with the American Cancer Society. Along with the HPV Roundtable team, she leads nationwide efforts to raise HPV vaccination rates and prevent HPV cancers with the ultimate vision of ending vaccine-preventable HPV cancers as a public health problem. Christina has been with ACS for 12 years. She resides in Boise, Idaho, and enjoys spending time with her family out in the woods, on the lake, or cheering on Penn State football. Welcome, Christina.
Thanks for the welcome, Casey. And I know there's a lot of Ohio State fans on here, so I probably should have taken that last part out of my bio. But I'm here to talk a little bit about the National HPV Vaccination Roundtable, who we are, and then you've heard some references from others about some resources we have. So I'm going to dive a little bit deeper into those resources, as well as a new campaign. Dr. Pascat talked a lot about that starting at age 9, and that's a big push for us right now. And so we have a lot of great new resources coming out around that. Next slide. So just a quick overview, and you kind of heard this in my bio, but we, as the HPV Vaccination Roundtable, are a national focus looking at organizations that come together collaboratively to raise HPV vaccination rates and prevent HPV cancer. So everything we do as a roundtable, we do in a collaborative space. So it's not in a vacuum, it's not ACS or us as individuals. We do it with many organizations nationwide that come together to kind of look at how we can best provide resources, data, experts that help lead your guys' work and provide things that help you guys to do your daily work as well. Next slide. So this is our national team here. I just wanted you to see the faces. Dr. Debbie Saslow is our leader in charge, and I hope that you've heard her speak before. She's phenomenal. And she is directing our team as the managing director for HPV and GYN cancers. We just brought Dr. Gabby Darville Sanders on, who is also phenomenal. So you'll start to see her a little bit more. And then myself, as well as our program manager, Lydia Hora. And feel free, at the end of this presentation, I have my email address. If there's ever anything you think you need in the community, in your clinic, please reach out. We love hearing what would be best of use for you guys. So even if there's a resource that we have that you say, you know, this would be more beneficial in a brochure or co-brandable or those things, please reach out as I go through the presentation and you get ideas. I love to hear that stuff. Next slide. These are our member organizations. Some you may recognize, some are a little smaller, but they all come together in different spaces. So some of them are more clinic focused, some more parent and public, but we have a really great mix and we're always looking to add a little bit more diversity and that sort of thing. But this is our current, we have about 70 member organizations. Next slide. All right, so you've heard reference to our resources. I just wanted to do a quick plug of where you find that, and you can see the link up there, but I can throw in links when I'm finished as well. But our hpvroundtable.org website, and at the top you'll see resource library. If you click that, it brings up all of our resources, and everything's filtered if you want it to be. And then we also put, if you just go to the resource library, it'll be what is newest added first. So you can kind of see the new resources on there. We add both products that we create as the Roundtable, things that American Cancer Society has, as well as our member organizations. So you'll see some dental toolkits from Team Marine. You'll see some St. Jude resources. So we try to make kind of a one-stop shop of whatever we have seen that's working best in the community and make sure it's available and accessible to all of you. Next slide. So I kind of quickly referenced our new campaign, and our priority for this year is the Start at 9 campaign. So we are looking at kind of spreading the word, gathering evidence, and creating resources around the fact that HPV vaccination should start at age 9. So the first one you'll see on the screen here is an evidence review. So it is 2 pages. I only have 1 page up there, but it has, all of this is on the resource library as well, but it has kind of what's known, what's new, as well as some data in there. And to that point, I'll dive more into what we're doing to collect more data, because a lot of our resources right now, where we talk about starting at age 9, is anecdotal. So we're always collecting a lot more data around that. The second one you see here is a 1-pager that has resources as well as the recommendations and endorsements from CDC, as well as ACS and AAP. We have materials there linked. We have videos on the side that are on YouTube that talk about age 9 and the benefits of age 9. And we'll always be updating and adding this as we get more things. And then the one furthest to the side is really great. It's a clinic poster. It comes in poster size or 8.5 by 11. It's co-brandable right there where you see the HPV Vaccination Roundtable logo. You can add your logo. And it just talks about the guidelines kind of updated with the age 9 and goes through all of those. And that has been a great resource for clinics and available to be printed and used as you see. Next slide. So our Start at 9 campaign, we've created the resource you've seen, as well as we have a landing page for Starts at 9. This landing page includes core messages so that you can use with your clinics or your staff, that you can talk about, you know, why age 9, what are we saying? And then we also have toolboxes that have provider and health system toolbox. We have a parent and advocacy toolbox, as well as a state coalition and local coalition toolbox. So in there, you'll have social media messages, as well as newsletter content and links to a ton of resources that you can use both in clinic and out in the community more parent focused. And so this is a campaign that rolled out probably a month ago, and we're adding things on an ongoing basis. So this was kind of round one. Round two, we're hoping to release some more videos of experts talking about age 9, as well as more social media resources. And so you'll see those come out in probably the next month or so. And then I think, go to the next slide, please. And then here we talk about the benefits. I think something's covered in the very top, but it says benefits of starting at age 9. And you've kind of heard these throughout, so I'm not going to dive too much into these. But like I said, these are a bit anecdotal. We've heard from providers, we've heard from parents, and we are collecting data on these currently. But I know one thing that I've been really excited to hear is this last one has been shown to be acceptable to systems providers and parents. There hasn't been much pushback about starting at age 9. It's more been pushback of how do we get our EHR systems alerting us at age 9? How do we, educate staff? How do we educate parents? But there hasn't been as much pushback about the actual starting at age 9 within clinics and with parents, which is great to see, and something that we as a roundtable take on ourselves of how do we then provide the resources to better educate, to better help systems and parents be more prepared for those conversations. Next slide. And to that point of most of our information right now being a little bit more anecdotal than we love, we have a call out right now for papers around starting the series before age 11, so kind of that focus at age 9. And we currently have a few different partners that have bought into write. I think we have about 15 submitted right now, and we're going to do a journal supplement in late fall that and then articles will come out on a rolling basis as well after that if there's some. But if you have an interest in submitting to this or know a clinic that is doing great with age 9 and has data to give, we would love to see it. We're trying to kind of create that evidence base so that in clinic, when people say, why age 9, you can reference this journal supplement and have the experts and the data and the research that you need to perform the work. Next slide. We're very active on social media. Our website is great, but we aren't able to update kind of those real-time things. So we use our LinkedIn, our Instagram, our Twitter a lot to do things like educational events. If you guys had something you wanted to advertise, we love to put that on there. It's more of our real-time getting information to you as fast as possible. So we use that quite a bit. If you want to follow us on any of those, just search HPV Roundtable. And we also have a YouTube channel that we put all of our presentations on. So when I'm talking about those age 9 videos of different experts talking about age 9, those will all be on our YouTube channel, as well as our current presentations are there now. And then next slide. We do have a national meeting this year virtually. It'll be September 28th and 29th. We have a landing page for it there on our website. We currently don't have registration up, but if you go to that landing page, there's a spot to put your email in. And if you want to be alerted when that comes up, we can definitely send you an email, or we will send you an email when that registration site comes up so you can register. We have some it's from 1 to 4 or 1 to 5 p.m. Eastern time. So we have some great presentations around age 9, around global HPV update, around the great data that's coming out around HPV as cancer prevention. And there's some great data coming out from some other countries as well that we're going to reference. And so it should be a great meeting. It's baseball themed, Vax like a champion. It should be fun. We try to keep it lighthearted. So we hope you guys will join us for that. Next slide. And then this last one is just kind of a recap, how to engage with us. But I think the biggest thing I want you to take away is that we have resources, we're available, and I want that conversation to be open. I'm happy to talk today where you see me, you hopefully get more comfortable with me, and you feel comfortable to reach out and say, hey, we created this awesome resource. I think it's something that nationwide should be used. Reach out, we can work with you to advertise or anything like that. We just want to be creating things that are helpful and really pushing us all towards that goal of increased HPV vaccination rates. So anytime you need anything or you have anything you want to discuss with us, please reach out. My contact's right there at the bottom. And I just want to thank Casey for having me today, and all the speakers. Your guys' presentations have got my head thinking about a lot of different things. So thank you so much.
Thank you so much, Christina. I think that I'm going to be spending a large chunk of my afternoon looking through all these resources. So really appreciate you sharing this with us. And I appreciate the time of everyone today for being here and spending your morning with us. Thank you so much to our planning committee that helped to put this presentation together. Thank you so much to our speakers. I hope that everyone here this morning has found something that they can really take back and use in their own daily practice in order to really reach that goal, reach the challenge that Dr. Paskett put before us to increase HPV vaccination, to begin eliminate some of the HPV related cancers and saving more than 30,000 lives a year. So in closing, we hope that you will join us for our next virtual forum. Next time we're going to be discussing health equity and breast cancer screening. So there's the date for that. Go ahead and mark it down. And I believe the registration is even open for that already. As a reminder, immediately after this session, you will be asked to complete a post-event survey. Completion of this survey is required to receive the continuing education credits. You'll also receive a post-event email with a recording of the session and the survey link, and your continuing education credit certificate will arrive in about 2 weeks after this session. So thank you to all for spending your time with us today. Please feel free to reach out to any of us. We really hope to work with you and to meet the challenge of being HPV cancer free. Thank you.